Afternoon, everybody. I'm Professor Greve. I'm Emeritus Professor of Bariatric and Metabolic Surgery at this university, and I'm replacing our Rector Magnificus as Pro-Rector. And I hereby open this academic session, in which Jan Soen will defend the academic thesis, Body Composition in Cancer, CACHEXIA. And may I invite you to present a summary of your study and the conclusions of your thesis.
Yes, thank you, Pro-Rector. 4 years ago, I aspired to contribute to science. 4 years later, here I am. Dear Pro-Rector, highly esteemed opponent, dear supervisor, my family, colleague, friends, and all of them join online. It's my great honor to be here. Right now, please allow me to show you my summary and main finding of my thesis, Body Composition in Cancer, CACHEXIA. Although cancer treatment received remarkable success in the past year, it remains a big challenge in the world, particularly in lung and gastrointestinal cancers, because there are 2.4 million new cases of lung cancer, and there are 1.8 million deaths of lung cancer. Gastrointestinal cancer even worse, because 4.8 million new cases happen each year, and there are 3.4 million deaths each year in the world. Why cancer still is a global health burden? Because the traditional chemotherapy will lead at least 60% of the people occur chemotoxicity. And the novel treatments, such as immunotherapy, they are so expensive. For example, the average of the cost is around 400,000 euro per person, and only few people could really benefit from it. Also, the precision and efficacy of those treatments has been improved. Each patient's situation is quite different. For example, physical condition is reflected in cancer CACHEXIA. What's a cancer CACHEXIA? Cancer CACHEXIA is a multifactorial syndrome. It is defined by weight loss, reduced BMI, and loss of muscle with or without fat. Cancer CACHEXIA really contributes to the treatment-related toxicity, poor survival, and reduce the therapy response. Affect up to 80% of patients in advanced cancer stage. It accounts 20% of cancer-related deaths. Identification of CACHEXIA can be challenged, since some patients present without apparent weight loss, and their muscle and fat change could be masked. There is a critical need for a new method to address the challenge in the future. Advance in radiology improved in identification of body composition in cancer CACHEXIA. CT scan are routine radiology method performed in diagnosis and follow-up. Meanwhile, the number 3 CT scan, we can use it to analyze the body composition. Look at the CT scan. We can analyze the size of the tissue, and we can also quantify the density of the tissue. Look at the CT scan. The darker place means a low density of the tissue. The green color, that means a high density. But composition, simply to say, is the muscle and fat within the body. CT scan based on body composition assessment can quantify fat and muscle very well. After analyze, we can clearly to see the muscle within red color, and the visceral fat within the yellow color, and the subcutaneous fat under skin within the blue color. We always like talking men and women, since we are so different. It's also reflected in body composition. Men always want to have much more muscle. Meanwhile, they also easy to gain the visceral fat. The women always want to be thin, like me. Unfortunately, they have less muscle compared with men, but they also easy to gain the subcutaneous fat. We can clearly to see the difference from the two CT scans after the analysis. Right now, it's time to show the study result on body composition. In part 1, we focus on body composition of cancer patients and their clinical characters associated with several clinical outcomes. For 1 century, anti-cancer drug dosage calculate based on patient's height and weight. However, some drugs love fat, some drugs love muscle. The difference can significantly impact the efficacy and the toxicity of the therapy. So, how does body composition influence chemotoxicity? With this question, in Chapter 2, we include 104 metastatic colorectal cancer. We analyze the body composition before chemotherapy, and we want to know the association between body composition and chemotoxicity. As I mentioned just now, the research question, the CACHEXIA research question is weight loss. My cat, Ricky's question is lose weight. He was sick because of fat. So the same issue happened in Chapter 2. Let's move to the result. We found the subcutaneous fat was associated with chemotoxicity. That means if the patients with low fat density, look at the figure, that means the patients they are more easily to develop the chemotoxicity. But if the patients with higher fat size, they are more easy to occur the chemotoxicity. So we can say Ricky is cute, but fat is not. Since we know how fat impact on my Ricky and chemotherapy, the new treatment are emerging to overcome the chemotoxicity. We were curious about how can body composition impact immunotherapy response. In Chapter 3, we include 120 advanced gastric cancer. This time, we still analyze the body composition before immunotherapy, and we were wondering how about the correlation between immunotherapy response and body composition before treatment. I would like to use 2 patients' case to show the difference of the body composition. The patient 1 with higher muscle density, the patient 2 with lower muscle density. We found that if the patients with higher muscle density, the better treatment response they have. Chapter 3 already shows the function of body composition before treatment, but cancer treatment may promote the body composition change, and we know body composition also affects the efficacy of treatment and patient's survival. We turn our attention from the baseline before treatment to the body composition change. That means the change before treatment and after the treatment. In Chapter 4, we include 76 advanced lung cancer patients with immunotherapy. They both have the CT scan before treatment and after treatment for calculate the change of body composition. We really want to know how about body composition change impact overall survival. I would like to use 1 patient's case to show how body composition change during immunotherapy. The first CT scan is before treatment. After treatment, we can see the patients lose muscle. In January, we know patients who lose muscle during treatment have significantly shorter survival. We observe the same things in immunotherapy cohort. We can see for 2 years survival range, In group of the patients who gain muscle, the 2-year survival rate is 47%. But in group the patients who lose muscle, the 2-year survival is only 14. This sparked our interest in employing the interaction between body composition and the tumor immune microenvironment. Tumor relief signal that infiltrate the fat and the muscle, and they cause a change both in muscle and the fat, but also activated the immune system, and the immune system also interact with fat. And the immune system also infiltrate to fat and muscle. Both that they can really contribute to body composition alterations. In the end, we found that the association between immune system and the muscle losing. The advance of radiology in cancer research is not limited in CT, but also includes PET. So, the key role of the part 2 is focus on the PET-CT. Body composition alteration is considered to be a consequence of interaction between tumor and human body metabolism. The tumor activity is not serve as a fuel for cancer, but also impact the body composition like the muscle and the fat. Since we use the PET-CT to capture the sugar uptake in high activity tissue such as the brain, look at the yellow area, also into the tumor. And we can also use the CT scan for body composition analysis. This brings us to part 2, PET-CT. We know the PET for analyze the tumor activity, and we also know the CT for body composition. So the question is tumor activity related to body composition? In chapter 5, we include 173 non-small cell lung cancer patients. We analyze both the body composition and the tumor activity before treatment. We observe that the patients with high fat density, they have a higher tumor activity at the baseline. As long as I explore the body composition in cancer patients, I always consider the novel radiology parameters and the dynamic of the body composition change during the treatment. In chapter 6, we include 136 patients, still non-small cell lung cancer. This time, we analyze the tumor activity before treatment, but again, we find the relationship with the tumor activity and the fat change. If the baseline of the tumor activity go higher, they independently let the patient's fat size go bigger during treatment. Finally, it's time to give a conclusion. Body composition impacts treatment efficacy and toxicity in cancer patients, emphasizing the roles of muscle and fat in oncology. Tumor activity and body composition interact and influence treatment response and survival in cancer patients. In the end, body composition analysis should be incorporated into routine cancer care to personalize treatment and improve patients' outcome. In the end, finally, both my Reiki and my research question call for pay attention on body composition. Thank you for your listening, and I give the word back to the prorector.
Thank you very much for your very clear presentation. And we will continue now with the opposition. The opposition will be opened by Professor De Ruijser. He's Professor of Radiotherapy, in particular Respiratory Oncology. And Professor De Ruijser was also the chair of the assessment committee. Professor De Ruijser.
Thank you very much, and thank you very much for this very interesting thesis. And I want to congratulate you and all the team, and also everybody who supported you for this endeavor. But I'm here to ask you some questions, of course, and throughout your thesis, you identify a lot of prognostic factors, whether it's the neutrophil lymphocyte ratio or FDG, CT scan, etc. But my question to you is, what are the actionable parameters in order to really improve the prognosis of patients?
Highly esteemed opponent, thanks for your question. First, I need to know which factor will play a key role in cancer cachexia. I think a lot of factors play a key role in cancer cachexia. For example, we know the systemic inflammation plays a key role in development of cancer cachexia. We know the CRP and the NLR, and sometimes the people also use the systemic inflammation index to calculate the inflammation. And we can also involve the TNF-alpha IL-6. For me, right now, we need to make the standard score to make sure which the factors can really play the key role in cancer cachexia. And for me, I think when I build the clinical modeling to really predict the clinical outcome, we always confuse about some confounder like the age, sex, smoking, and the personal history, and the stage of the cancer, and the cancer type. So in the future, I would like to involve as much as possible. What I mean is the cancer population, and we can involve the different type of the cancer, and we can also consider the race and the age, and we can also use the body composition. Right now, there are different cutoff to really define the cachexia. For example, the sarcopenia was so different from the United States or Canadian or European or Asia people. I think it's better involve all of them in the basket, and based on that, we can build a standard score. That's what I think.
But this is still a prognostic model. So basically what you're saying now, if I understood it well, you will increase the number of parameters, and you can use maybe 100,000 patients or 1 million patients, and you will explore more parameters, but still it will be prognostic, and you will allocate a prognostic group or maybe come to a really individualized prognostic score for survival or toxicity or whatever, but it's still prognostic. So my question still remains, what is actionable? How can you change the fate of patients? Or will you say, well, this patient had a bad prognosis, I will not invest my money nor the toxicity for a certain treatment, which is good, but still, how would you improve the biggest group of patients who still have a very bad prognosis? I'm working on a daily basis with lung cancer patients, and still, as you know, most will die of their disease. So my question still is, what is actionable in CACHEXIA? So how can we make it reversible? And do you have some ideas where you should move to? So really actionable in the sense that how can we do a pharmaceutical intervention or nutritional intervention or whatever to improve the prognosis of those patients which you have identified as having a bad prognosis?
For identify, I think as much as data we should improve, and for me, I personally think the communication is very important because everyone has their limitation. We need to discuss with different people from the different field. For me, I think we can consider the CT scan for analyze the patient's body composition and put the result into the reporter of the radiology, and radiology result. We can ask the experience from the nutrition.
Sorry to interrupt you, but so my question is, do you think there's a metabolic pathway or several metabolic pathways with novel agents that you could theoretically intervene with in order to improve the prognosis, so to make cachexia, again, reversible, basically?
To be honest, I'm not really sure, but right now I think we can, around the diagnosis, we can try to predict the cancer cachexia risk for the future. And if we can ask for example, nutrition counseling, we can try to give the nutrients at the diagnosis and try to reverse the cancer cachexia risk in the future. If possible, we can also involve the physical exercise at the really beginning, and we can also use the parameter from the radiology to really monitor the follow-up and to see how about the treatment can really respond to the patients.
And in chapter 2 you say that nutritional support didn't help, so basically isn't the answer getting rid of the cancer as quick as possible?
Please repeat again.
So in chapter 2 you say, well, nutritional support doesn't help anyway. Isn't the answer actually to treat the cancer adequately?
The chapter 2, I think we focus on the chemotoxicity. Right now we calculate the dosage based on the body surface area, but we know the drugs, they have the hydrophilic and the hydrophilic. For example, the drug like the oxalipton is a hydrophilic. For example, we call for pay attention for the obesity sarcopenia. That means the patients with a higher weight and but they have a lot of fat and less muscle. That means maybe the calculation of the dosage may be overdose, will lead to chemotoxicity. So in the future, shall we consider take account into the body composition into the personal dosage calculate and really support to the personalized treatment?
Okay, thank you very much. I give the word back to Mr. Pro-Rector.
Thank you, Professor de Ruijser. The opposition will be continued by Dr. Zielander, Associate Professor and Head of Cancer Metabolism Research Group at the University of Sao Paulo, Brazil. Thank you for being with us from all that long distance. Dr. Zielander was also a member of the assessment committee.
Thank you very much for inviting me to evaluate this exciting thesis. It's been a pleasure, and I'm very grateful for the rector and the pro-rector for the invitation, and also for the supervisor and the whole team. So I would like to start this by asking you what you think about functional parameters, because you did not include these in your methods or results, and you also do not really comment on these parameters along your thesis. As we think that, for sarcopenic obesity, I just came back from a sarcopenic obesity meeting in Rome, and also for cachexia, function has been discussed as and also believed to be a very important component of the assessment in outcome of treatments and also for survival. So I'd like you to comment on that, please, if you could.
Excuse me, can you repeat the question again, because I couldn't listen clearly.
Okay, so I'm actually asking you to please comment on the role of function, muscle function, because you have not assessed this and you do not discuss it very much, despite the fact that more and more scientists are taking these into consideration, not only muscle mass, adipose mass, but also function. Do you think muscle function should also be evaluated, perhaps in the sense that the professor before me was saying, to improve diagnosis and also to treat the patients and to assess the outcome of treatment? So the question is function. Is it important, muscle function?
For now, I know the muscle play a key role not only in cancer research, also plays a key role in aging. We know if the patient has enough muscle mass and enough radiation attenuation, they will probably live longer. For me, I think we use the body composition to analyze the muscle both mass and the density. We can use it to predict the clinical outcome. For right now, I'm not really sure how about the function or the metabolism, but I do know maybe the muscle can really impact the drugs distribution and the metabolism in the body.
Thank you. So another question I have is any correlations you could have found between your results and sex, because you mentioned sexual differences in your presentation, but I did not find any results or comments on these differences. And you have patients as both female and male patients in your cohorts, right? So correlations with sex and also correlation with tumor staging. That's I'm also curious about. Thank you.
Highly esteemed opponent, thanks for your question. For first one, the sex, I think, to be honest, is a pity because we have a small cohort, and we can see in several chapters the sex for the female and male is not balanced. For example, in chapter 2, we focus on the chemotoxicity. In female group, only 38 patients, and in male group is 66. So that means if we do the statistics, the group is not balanced, we will lose some statistical power. So in the future, I would like to involve much more population for the patients and try to make the group be balanced, both for the female and male. Then we can compare how about the difference between the female and male linked to the different research outcome. And the second question is, can you repeat again?
Yes, tumor stage, because you have tumors ranging from 1 to 4, right? And so do you think this plays an important role in the results you see, or is there any relationship between the body composition at baseline and the stage of the tumor?
Yes, thanks for your question again. Normally, I think in my thesis, most of my study population, they are advanced cancer. So that means they from the stage 3 and stage 4. So that's why I'm not really focused on this point. But to be honest, if we have a bigger cohort, I need to analyze from the stage 1, stage 2, stage 3, and stage 4 because it's a very important confounder. No matter for analyze the cancer survival and the chemotoxicity, it will play a key role. And I would like to set a different subject and focus on the different stage. And we want to know if the patients from the same stage, how about their body composition, no matter from the baseline and also from the change of the body composition, try to predict the clinical outcome.
Thank you. Another question I have addresses the inflammatory aspect of what you're discussing, because you put a big weight, right? A heavy weight on inflammation. You discuss inflammation, but you're relying on PCR and some other markers that are not, as you mentioned in your talk, right? IL-6, I1 beta, TNF alpha. Of course, I know it's expensive to measure that everywhere. But one thing that has been easy to measure, I think, is ratios. And you can say that the patient has a more or less inflammatory status. If you measure, for instance, one of these cytokines, a pro-inflammatory cytokine, an anti-inflammatory cytokine, or if you look at adiponectin versus leptin, and then you can find out scores, right? So I think that I would like to hear your opinion about how you think inflammation is contributing. Is it inflammation that is already present before at baseline, and that is, preventing treatment success? Or is it inflammation caused by the treatment itself?
Thank you for your question. For me, right now, I think we already know a lot of score to analyze the system inflammation. We know the Glasgow, and we know some biomarkers to really label the inflammation style, and we also know the CRPs. They also runs a different cutoff. In my chapter, we also analyze the NLR, and we use the RC curves to make the cutoff. Really depends on the study population. But for me, I think the inflammation is not black or white, because we know the tumor drives the pro-inflammatory factors such as the TNF-alpha and IL-6 and IL-8, and they will impact on the human body's immune system, and they interact for each other. And in the end, we not really sure they really contribute to the muscle wasting or the fat remodeling, because in one review, if I remember correct, it names the interplay, immunology and the cancer CACHEXIA. They found that the inflammatory and the immune cells, some they can really against the cancer CACHEXIA, and some is not, like the CD4. So in the future, I think we can involve as much as biomarker. I know the study from the Brazil, they involve the gastrointestinal cancers, and they group with non-CACHEXIA and CACHEXIA, and they label the inflammation level like the IL-6 and the IL-8 and the CRP. They also involve the leptin. They try to find the collaboration with body composition alterations. So in the future, I call for involve the much more population and much more biomarker, and I try to make a standard score to really label if the inflammation plays a key role in cancer CACHEXIA. Thank you.
Thank you. So in regard to the tumor itself, you've analyzed the lymphocyte cells, right? The lymphocytes that are infiltrating the tumor. And then you imply that they are involved in inflammation. But we cannot forget that also we have different phenotypes of macrophages, as you also showed that there are different phenotypes of lymphocytes. So one suggestion I would have for your publications that you intend to have from your thesis is that you comment on the interaction between macrophages and lymphocytes, and you have a look at the proportions of different types of different phenotypes of the lymphocytes you're having there, right? And if I have, sorry, go on.
Continue, please.
Yeah, maybe we should make this a bit short, if you don't mind.
No, yes, I just had an extra comment. It's about browning that, comments on browning possibility as increasing the metabolism of the adipose tissue. And I wanted to know your opinion, if you believe browning is happening in human patients, and if it's not really only in the rodent models. Thank you.
Thanks for your question.
Very, very short answer, please, and we can continue.
Okay. For me, I'm not really sure the browning, because the browning adipose tissue is not a standard, because if we use a PET-CT scan, we can really see the browning adipose tissue around the neck, and it's really common in the children, if I remember correct. And it's also impact on the temperature. I remember a literature came from Karolinska. They found if we control the temperature and really impacts on the browning, and is contribute for the cancer patients. So for right now, I'm not really sure. We need to try to take a biopsy from the adipose tissue and try to link to the radiation attenuation to see if the really high adipose tissue radiation attenuation really associated with browning.
Thank you very much. Okay, to go back.
Thank you, Dr. Zeelander. The opposition will now be continued by Dr. Van Norren, Associate Professor at the Human Nutrition and Health Department at the Wageningen University. And she was also not a member of the assessment committee. Dr. Van Norren.
Okay.
Dear candidate, thank you for sending me this nice booklet with also nice yellow, blue and green that come back in your CT scans. And, so I would like to, I read it with pleasure, and I would like to go to you with chapter 2, to table 1. And in table 1, you see that your visceral fat radiation and your subcutaneous fat radiation, they both increase, and they both increase significantly.
Yes.
And if you then go to the next page and you look into the multivariable analysis, then you see that only the subcutaneous fat really associates, while the other really has a very different p-value. And the same thing you see also in chapter 5 for a completely different tumor. So here you see it both for colorectal cancer and the other for lung cancer. And you see the same phenomena. So you see both significantly going up, but the association is only for subcutaneous fat. And I was wondering, what is going on? Why is the one associated and the other not, while they go in the same direction?
Highly esteemed opponent, thanks for your question. First, I would to say both the visceral fat and the subcutaneous fat, their location and function is quite different. They play a different role in the body composition alterations. And if we run the clinical model, we always consider the population. So we can see the population, study population is different. Maybe the cancer CACHEXIA is really different from the different type of cancer. And the other thing is we know the body composition, maybe they still have the collaboration between the fat and the muscle. And we also know the schedule.
Sorry, I don't think you have my question right. So what is the difference between visceral fat and subcutaneous fat? That both fat tissues are going up in Hounsfield units, but the subcutaneous fat is associated as a risk factor with a nice p-value in both cancer types, but the visceral fat is not at all. So why are they moving in the same direction, but they are completely differently associated?
I think the subcutaneous fat first as a storage of the energy, because we know the tumor need a lot of energy because they have a big burden, and during the tumor progresses, maybe the subcutaneous fat will contribute to the tumor metabolism. So we can see the subcutaneous fat radiation attenuation go higher. The potential reason, as Dr. Silander mentioned, the browning. The other thing is fibrosis. I think the fibrosis is easy to understand because the fibrosis means a higher density. The other thing is the potential is inflammation, because some literature already proved there is association between the subcutaneous fat and the insulin resistance, and we know the tumor drives the pro-inflammatory factors, and they will lead the insulin resistance, and the insulin resistance will contribute to the tissues change. For example, the muscle and the adipose tissue remodeling. To be honest, I'm not really sure which kind of fat plays a key role, and we also know during the tumor progresses, the skeletal muscle radiation attenuation will also go down. That means fat will infiltrate to the muscle, and I'm also not really sure where is the fat came from. Probably from the subcutaneous fat, the SATRA. I think that this is a limitation for the future I would like to explore.
Okay, thank you. And you already mentioned the fat infiltration in the muscle. Why is it a problem in cancer CACHEXIA? For example, in marathon runners, you see that muscle really benefits from lipid droplets in the muscle. And here you see lipid droplets in the muscle which are damaging, probably. So what could be the difference here? Can you speculate on it?
You mean the skeletal muscle radiation
Yeah.
attenuation?
Yeah.
If we see the low skeletal muscle radiation attenuation go down, that means the fat impacted into the muscle. I think it's a pathology pathway for the patients, not only for cancer, also for the age. Probably because the insulin resistance, as I mentioned just now, and some studies, they take the biopsy from the muscle and they staining the muscle and they found the lipid into the muscle and they found the collaboration with cancer CACHEXIA, and we know the cancer CACHEXIA is a development of the cancer. So I think that is a way to predict the clinical outcome. And for the fats, for me right now, I'm not really sure because I think it's a potential space for the future study. Like we can have some outcome cutoff to divide the subcutaneous. We have some cutoff to divide the high and the low skeletal muscle radiation attenuation and the mass, which means the area index. But we don't have the cutoff to divide the high subcutaneous adipose tissue, no matter index and the radiation attenuation. So in the future, I would like to take a biopsy of the fat, both for the visceral fat and the subcutaneous fat, and I really want to see how about the factor of the tissue and plays a key role in development of cancer CACHEXIA.
Okay. I still have time? No? I would like to give the word back to
Thank you very much for this very interesting discussion, but we have to continue. So the next proponent will be Dr. Mitea from the Department of Nuclear Medicine at this university, and she was also a member of the assessment committee.
Thank you very much. Dear candidate, I want to congratulate you and your team with these really nice results and also the book. And I want to focus myself on chapter 6, that was our lung cancer and also hepatitis. You describe in the study that patients received different doses of FDG. So imagine 0.14 and 0.21 millicurie per kilogram. Did you take into so when you analyze the results, did you take in consideration that the different doses could influence your measurements?
Highly esteemed opponent, thanks for your question. First, what you mean the dosage?
You describe on page 138 that the FDG dose was between those per kilogram. So normally we use, so in nuclear medicine, we use a standard dose per kilogram. Then we ensure that what we measure with the scanner, it's uniform, so it's the same in all patients. Did you take that into consideration when you
To be honest, I'm not really good at in this field, but I think I need to consider for the future. For now, for my knowledge, I think the dosage will impact on the parameter, and I also know the parameter also have some factor we need to overcome. For example, the temperature of the room and maybe some chronic disease like the diabetes and the glucose level, and we also need to consider some novel parameter to overcome some parameter as like SUV will impact by the patient's weight and is not accurate for the noise. So that's why we want to involve the novel parameter and try to consider the dosage.
in this one? Okay, so normally there is a way to make the results uniform. So, but you're right. So this will influence, and also the other parameters that you named are also influence the result. I want to come back to the question about the fat. I found it really interesting that the amount of subcutaneous fat increases in these patients. And I really liked your quote in the presentation when you said that some chemotherapy loves fat and some chemotherapy loves muscles. Do you think that the results could be influenced of the population that you choose and the chemotherapy that was given, or do you think that it's a general concept, so that you see increase in subcutaneous fat after chemotherapy in cancer patients?
I'm not really confident for it's a general conclusion. For me, I think we need to consider the result is just based on this population study, and we know the population, the patient is not a lot. So I think it's a limitation. In the future, if we want to explore more the PAT parameter and the body composition parameter, we need to take account in different type of the cancer and also from the different cancer stage. Then we have a result and really show some evidence for this part.
Thank you. Do I still have time for one short one? Okay, no short. Okay. I would like to ask one of the paranames to read proposition number 1.
FDG PET-CT imaging emerges as a transformative clinical tool, offering new insights into nutritional status and survival prognosis by simultaneously capturing the metabolic activity of tumor, skeletal muscle, and adipose tissue.
Thank you. This is a different way on looking at FDG PET. Normally we use it for just standard categorizing the cancer patient. How do you propose, or what do you think, how can you use this method in the future? Do you want to implement it like a normal screening in all the patients, because not all of them, so not all cancer patients get PET-CTs. So I'm curious about your thoughts about that.
First, I don't think all of the people will perform the PET-CT because it's really expensive. Normally, we use it for the cancer patients and want to monitor is there some metastasis into another place, not only focus on the primary tumor burden. And since we know the PET-CT combines the PET and the CT, and right now we can use the CT for body composition analysis. If we can also use a PET to measure both the tumor's metabolic activity, and also we can measure the tissue like the muscle and the fat activity. If we can find the link between the tissue's metabolic activity and the body composition change, so we can really see during the cancer progresses, the tissues wasting or remodeling really contribute to the cancer progresses. And based on that, I think we already pay for the money for the PET-CT, and we can expanding the using in the future. If we can include the result to the radiology report, we can ask the nutrition counseling at the early stage around the diagnosis. We know the risk in the future. We can involve the nutrients, and we already discussed the muscles function just now. If we can also involve the physical exercise to help the people build the muscle, and we can ask the advice from the radiology, oncologists, and it's really good for build the personal treatment. And we can also try to consider calculate the dosage based on the electrophilic and hydrophilic. So just pay one time, and we can use in the different field.
Thank you very much for your answer. I'm happy with the answers and give the word back to you.
Thank you very much, Dr. Mitea. The opposition will be continued by Professor van Schoten. He is Professor of Genetic Toxicology at the Maastricht University, was member of the Assessment Committee, and is also Secretary of this committee.
Thank you so much. Compliments with the work. I read it with most interest, really interesting clinical results. I have questions on mechanisms, but also on methodologies. If you go to chapter 3, there's a study with gastric cancer patients, and you made a model to predict tumor regressions. And if you go to figure 3 on page 70, you have a training set and a validation set. And I do not really understand how you use the validation set. So my question is, if you go to this figure 3, and then you have plot B and plot F, and you see the regression rates, and then you build the model on the training set, and then you validate on the validation set. How did you do that, and how did you choose the parameters? How were those selected?
Highly esteemed opponent, thanks for your question. For this chapter, first we focus on the data, and we are not really sure it's really true in another cohort. So we found the same patients receive the same treatment, but I think the limitation is the cohort, the validation cohort is really small. So we can't really find the totally similar result as our beginning cohort. I think in the future, I would like to improve in this part. Maybe we can involve another clinical center and as a bigger cohort, and use the same parameter. And for the parameter, the skeletal muscle radiation attenuation, I already mentioned. We have some study already show link to the poor clinical outcome, and we also found the same result in our study. And for the NLR, as we discussed earlier, we know the inflammation plays a key role in cancer cachexia and also in cancer. So that's why we involve the NLR, because it's really easy to get. And when we talk about the definition of the cancer cachexia, the weight loss always discussed. So we're wondering, is there the association between the weight loss and the treatment response? So that's why we consider that.
Okay. So, but for instance, if you do the studies with the training population, you train your, for instance, your algorithm, if we are talking about artificial intelligence, like machine learning, and then you use the parameters selected there in that model, and then you validated model again on the validation set. This is not what you did in this study. So I wonder, can you do such a kind of approach and then introduce more parameters and maybe more features of the patients?
I would like to use more parameters, but the point is, if we want to run a clinical model, we need to consider the event, which one we want to predict. And if we involve a lot of parameter, we will lose the statistical power. So first, we need to consider the sex and the age, because it's really important. We use it as a control variable. And the second, we also consider some variable. The parameter plays a key role, probably really linked to the research outcome, like the inflammation.
Okay, so that's what you did. Can I have more time for another question?
2 minutes.
2 minutes. Because I was also puzzled by the mechanistic explanations of your findings, and I wondered, how can body composition influence the pharmacokinetics and the pharmacodynamics of the chemotherapeuticals?
Thanks for your question. Right now, I think it's really difficult to answer, because we know every treatment, we combine different treatment together. For example, radiology plus chemotherapy. For the chemotherapy, we also involve the different drug, and some drug is electrophilic and some drug is hydrophilic. We are not really sure which drug plays a key role in the whole metabolism. and how about the distribution. I think for right now, it's better to build a modeling just to test a single drug to see how about the drug, the pathway in the whole progresses. That's what I plan.
What you plan to do. Okay, so because you also said body surface area is maybe not so relevant, that you should go for body composition by adjusting treatment dose, but that's also what you're planning to do, and more research is needed. Yeah, so I'm pleased with your answers, and I give the floor back to the prorector.
Thank you very much, Professor van Schoten. The proposition will be continued by Dr. Bouwense. He is a hepatopancreatobiliary surgeon at the Maastricht University Medical Center. Dr. Bouwense.
Thank you, Mr. Prorector. Dear candidate, congratulations with this amazing work. I think it has been a difficult task working with cachectic patients and also predicting who's at risk for dying of the tumor, eaten away, or solving the issue. Congratulations to the whole team. I think there's a lot of novel work to do, and this is one of the great research lines we have in Maastricht. And also congratulations to your family and your colleagues. I'm a surgeon, so I don't have a lot of knowledge about CACHEXIA, and my colleague, he started about discussing should we get a tumor out or not, and who should we select. And I was a bit puzzled about the proposition, and it was proposition 2, and perhaps one of the paranyms could speak up and read it to us.
A single baseline measurement of body composition should not be used for predicting clinical outcomes, because body composition and anti-cancer treatment influence each other.
So when I read this and I saw your results of chapter 2, I thought, okay, what's happening? I have a cachectic patient, and when you read this proposition, knowing that this patient is cachectic, but it doesn't predict survival at that moment. But when I went to the Kaplan-Meier curve on page 46, there seems to be happening something with the cachectic patients and the non-cachectic patients. What should I do with that?
First, a highly esteemed opponent, thanks for your question. For the statement of 2, why I talk about the single baseline measurement of the body composition? Because we got the CT scan around the diagnosis or before the treatment. That means is after the tumor happened. Probably the body composition already start before the diagnosis, which means start before the CT scan. So I think the body composition alterations already happened before we analyze it. Right now, I think it's a limitation because maybe we will lose some follow-up CT scan for the patients. So in the future, if we can have the CT scan really close to the diagnosis, we also have the follow-up CT scan, and we can calculate the change, and we can really use the dynamic body composition to predict the clinical outcome is more accurate than the baseline CT scan.
Thank you, that's clear, but still it puzzles me a bit. And I agree with you that there are some patients that you see changes in cachexia, and usually when patients become more cachectic, those are the bad ones. You shouldn't operate on them, and perhaps you can't even cure them. But also we know that some patients are just becoming more cachectic and cachectic when still the tumor is inside. What is a way of a basic set of all the measurements you have done that could help us out to select patients upfront for upfront surgery or waiting rehabilitation with all new ways of improving the health of those patients and even providing tumor treatment?
I think the first thing is we got the CT scan and we try to understand the patient's phenotype, and if we can involve as much as a clinical data, we can try to find some. We can try to predict the risk in the future. So for the KM curves, I think the limitation is the cutoff to divine the CACHEXIA. For example, the high central and low central for right now is not clear. So in the future, if we have much more cancer patients, we can make a clear cutoff to really define which group will be more easy to develop cancer cachexia. And as I mentioned now, we can try to consider the nutrition counseling and support the patients before the surgery or after the surgery, and try to adverse the risk in the future.
Okay. And if you're thinking about future research, you have access to perhaps bigger populations with more different patients, where would you put your money on? Should we focus on PET-CT? Should we focus on inflammation, insulin resistance?
I think it's a good question. I think first I want to use a part of the money to run the body composition analyze, help the PET, because right now we still need the radiologist help to segment the interesting area. If in the future we can improve this part, we can save the time, and in the other part, I would like to involve use the money to.
You can briefly answer the question, or you can say it's okay now.
I would like to continue. Because right now I'm also confused about the inflammation factor. So I would like to use the money to pay more people. We can involve the more biomarkers, and we can try to build the score and make it be standard. So we can use it for future and save time, save money in the future. If not enough, we can consider to start a business and try to make our own funding.
It's not the business.
Thank you for this answer, and I'll give back the word to the Mr. Product.
Thank you. Janssen, the time appointed for defending your thesis has passed. The degree committee will now discuss the quality of your thesis and your defense, and I request you and your company to leave this room so we can make this consideration, and you will be brought back by the.
Perfect.
Net zoals je al zou zitten. Ja, dat klopt.
Ja? One can sit here.
We can share one.
Janssen, the degree committee here present has assessed the quality of your thesis and of your defense.
Yes.
In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Olderdaming is authorized to confer upon you this academic distinction in accordance with the Dutch university custom. I invite your supervisor now to take the floor.
Please all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer you upon Jan Sun the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, I now present to you the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. This is a difficult bit because it slips. Congratulations.
Thank you.
Please be seated.
Jan Sun, Dr. Sun, what a way that you traveled. Chinese is not around the corner, it's not like that I did, just Twente to Maastricht. But I'm talking about, you know, your whole way that you traveled. When you started your academic career, your medical degree, your scientific degree, the career that you wanted to embark, then your father advising you to do a PhD in Japan, to look at labs in Australia. But then you said, no, you know, I want to go to Maastricht because I saw a presentation of a Maastricht professor in Wuhan. And I thought, you know, that's interesting. You're thinking about cancer CACHEXIA. So that is now almost 4 years ago, I think, that we went on Zoom with Sander. I don't think that David was on Zoom. And then we had the first discussion where you said, you know, this is what I want to do. I like the way what you did. I looked at the Chinese PhD students that were in Maastricht, and this is what I want to do. So we decided that we should do it. And then all of a sudden, COVID. So the COVID made it even more difficult for you because it's very well, you know, written by your extensive, you know, gratitude to everybody that helped you. But there you stayed and did what Jan Sun does, to work for other people. And then that is one of the things that I at least learned from the 4 years that we were working together, that you always take care of other people, that you're always in the middle like, you know, a spider in the web, or the glue or the oil that needs engines, that the engines need. That is actually very remarkable, and that's what I think everybody could read and see when you looked at your thesis. And then you arrived. And then, you know, what could we do? Just after COVID, you know, there was no ongoing trial. So at the beginning we thought, well, let's put Jan in the lab. And Jan went into the lab, but Jan and the lab, that's not a good marriage. So after, I think, 2-3 months, we decided, you know, this is going to be your first breakup of a wedding with the lab. So that is, we decided to do something different. And then we had a problem because how can you do a 4 years PhD when there was no plan for a scientific, you know, patient-driven study? Another very, very, very good talent of you is that you're very creative of getting a solution. And it was not only at that time, but also in the remarkable 4 years that we worked together. Because what did you do together with Minh Ding, who's now in Oslo doing his postdoc? You thought, okay, there's no study in Maastricht. We approached I think it was even the nuclear medics, but certainly the pulmonology. We thought about all kinds of studies that we could do. But then you said, I'm not going to wait for that. Let's search the web, and there you found, web-based material from Stanford that you were able to use because it's openly, publicly available, and that was your first thesis, your first paper. So that was the first time that you were very creative in finding a solution. And then, you worked as a global citizen, because I think that is really who you are, a global citizen. You worked across the globe. You worked with Amsterdam, with Carolina in Lisbon. You can see that at least you had 2 different cohorts in China. So you were always able to find a solution, although it was not easy. And that is, I think, one of the most precious talents that you have. The other talent that you have is to, forget about Jen. That's what we noticed today in the presentation. Jen is there full with her ideas, and then there's a question, and you immediately bombard with, this is what I want to say. So the thing that I hope that we could give back to you from the Netherlands is to just ease a bit. Ease, spend time with the alpacas on my land, barbecue with me, and think, tomorrow's another day, because I think that for the next couple of years, this is the only thing Jen needs. Jen needs to relax, sit back, chill a bit, do a barbecue with me and look at the alpacas, because then it will be perfect. The other thing, and that will be the conclusion, is my impression of your future, which I saw, and I see that the WYSS boss is even here. So I saw another talent in you. So I'm not sure if we have now 300,000 followers, because that is the amount of followers that you have on the social media. But you run the show there. You interviewed the people. You were a host. You even got your prize from the new. How do you call it, representative of Chinese for the European government. So that's known. It was not only for Belgium, but it was really, I think, a very, very prominent Chinese member of the Chinese committee. Being able to integrate with, my guys in the lab, with the other people that you do research with investors that were there too, with scientists. You even went to Beijing and met a member of a committee of one of my, PhD students for 2 weeks ago. You were interviewing everybody. So I think that is very, very very precious talent that you have, is to communicate, to be the glue, be the spider in the web, be the oil of engines, and then combine your talent with the future of the young scientist, to teach them how you did it and how you can survive even with COVID, even without a plan, and how you can come up with all these new ideas. So congratulations again, also on behalf of your team that suffered in helping you to the end. No, that was a joke. And hopefully we can celebrate this evening. Congratulations.
Thank you so much. Please let me thank you, all of you. Without all of your help and support, I can't achieve the achievement like today. And thanks for your support, Stephen. For me, I never imagined what I can achieve like today, no matter the influence or science or from the clinic. I just enjoy helping people, because when that's settled, what was chosen, it is true, is I want to live a wealthy life, and I want to have a value of my life. So that's what I think. For the success, I didn't think about that yet, but I try to help people, no matter from the clinical or science field or industry, because I think we'll create a good cycle for the people. We can really feel the beauty of the humility. That's what I expect in the future. Thank you again.
Well, thank you very much. We're nearly ready, but not totally, because I also may congratulate you with your title, Dr. Sun. on behalf of the Maastricht University, I congratulate your team, your promoter team, which did a great job in getting you all the way here. And of course your family, friends, and all the viewers maybe, I don't know. You did a great job. I understand that you will stay a bit longer in the Netherlands, and maybe it will help that your name is quite similar to a Dutch name, because when you say Jansson, it's Chinese, but when you say Janssen, it's very Dutch. It's very complicated. So you're already adjusted there. I saw that you're really a very accomplished person, not only a scientist, but also a painter. I really enjoyed the papers, the paintings on your thesis. You entertain many people online, as I understand, so you have so many qualities, and now you have added a little bit to that. And of course, the Maastricht University is very proud to have you as one of their permanent members. Your name is now definitely attached to the Maastricht University. For some practical things, we will go out with the promoter team to make some of the pictures on the stairs, the official pictures. And I understand there will be a drink, but that's not here in the university, we have another location, so I presume everybody knows where to go. And having said that, I hereby close this academic session. Yeah. Yeah.
You have to be very careful with this. This bird.
So let's first stand in front of the screen.